Have you ever heard about the term tennis elbow, golfer's elbow, patellar tendonitis? They all kinda sound like something related to irritated tendons, but you don't really know what to do about it. In this video, we will show you how they all act similar and how to treat most or any tendon pain. So in terms of physiology, this is the Achilles tendon located in the lower leg, and the structure of the tendon is divided in cells and cables, which we call fascicles or fiber bundles. These in the end, they have complex structures. Most importantly, they have their blood supply in the most external part, and as we go deeper, we can find the collagen fibrils along with tenocytes. So basically they form a structure like similar to a rope, but with some sort of elasticity that allow us to contract the muscle, that allow us to store energy and act sometimes like a spring depending on the demand we put on them. So in regards of tendinopathy, the mechanism in which it affects is very complex and still studied, but it's mostly based in the degeneration and reactivity of collagen, of those fibrils we were talking about. At some points they get disorganized and they literally stop working, or they are more sensitive. So it isn't fully understood, but something we know now is that some sort of inflammation is present, but it's not the main driving factor. This was an old model of understanding tendinopathy that isn't really what we understand today. So why does this happen? Why does a tendon become irritated? Why does it hurt? Why do we develop this pathology? Well, there's a wide range of risk factors. We don't really understand why, but it is likely due to lack of proper loading of the tendon or excessive loading in certain periods of time. So main risk factors end up being overuse, repeated injuries, sedentarism, and age. This is a slice of what we would see in the tendon. What we understand today as the driving factor for pathology is what we call reactive and degenerative portions. Degenerative portions are, we can kind of understand them as dead zones of the tendon where they are really inactive and they won't ever become active again. So it's a model where our tendons, as we age, as we use them as part of normal aging of the human body, they end up having degenerative portions. But what seems to be the main driver of pathology in terms of pain is what we call the reactive portion. The reactive portion is a state of the tendon where it's most irritated, it hurts, it is more disorganized in its collagen fibers, and it gives us pathology. So our current model for understanding tendon is where degenerative portions they cannot change, but reactive or normal portions can interchange between each other. Our tendon that hurts can become organized again and not give us pathology. So in terms of diagnosis, there's three things we need to keep in mind, and they are the presence of structural change, which is what we talked about before, about those reactive and degenerative portions. There's presence of pain, which is what we are most used to. This kind of pain is localized in the area of the tendon. It usually appears with movement or with contraction of the muscles related to that tendon. And it's usually worse in stretch position, so if we stretch the tendon, it usually hurts even more. And there's also presence of dysfunction, which is a loss of strength. These three symptoms or signs, they can be present, all of them, or only certain ones, like the model as we understand it today, we can have structural change with loss of strength but no pain. It's an ever-changing model, and each different kind of combination of these symptoms will give us different kinds of pathology. So common tendon injuries you may have heard about: tennis elbow, rotator cuff, gluteus medius, Achilles tendon, patellar tendon. They all kind of work the same, and the rehab process is very similar to all of them. The main difference is which kind of people are gonna get this, because patellar tendinopathy is very common in jumping young athletes, while gluteus medius tendinopathy is very common in sedentary older women. So it's mostly about the kind of activity, the kind of sub-classification of people we enter in. So similar terms you may have heard, which may be confusing: tendonitis. This is the old model based on inflammation, where we thought that the main cause of pain was inflammation of the tendon. As we said before, there seems to be some sort of inflammation, but it doesn't seem like the main driving factor of pathology. Tendinosis, which only, again, an old model which only described degeneration. As we talked before, current model says there's a bit of degeneration, there's a bit of inflammation. It's a compound of mechanisms that generate tendinopathy. So tendinopathy is the current term describing structural change, pain, and dysfunction. Tendon pain syndrome is the type of tendinopathy that is characterized mostly by pain. As we said before, some symptoms of the tendinopathy can be present or not. Tendon pain syndrome is a type of tendinopathy, mostly describing pain. So they are all used for the same kind of pathology. The name is usually indifferent because it's usually poorly used. So if you've gone to the doctor and he's diagnosed you tendonitis, we are usually always talking about the same thing. We just, as healthcare providers, we use them interchangeably and we don't really use them properly. So that's why I would say the name is indifferent. Don't worry if your doctor said tendinosis, tendonitis, whatever. It's all the same thing. Just to remember, the most recommended name currently is tendinopathy. So what can we do about it? Let's get an example. This is Adrian. He's a young basketball athlete. He's in his 20s, and he started developing knee pain under the patella. As we said before, this is very common between young jumping athletes, and this process applies to most tendinopathies. So just if your case is for tennis elbow, just copy these steps with exercises for tennis elbow. So our rehabilitation process would be divided in different phases. The first phase would mostly be consisting of isometric exercises. In this phase, we are just trying to control pain, to prepare the tendon to organize again, to contract again. We are giving it the minimum load, stressor load, to the tendon to actually get organized again. So in this case, we would get knee extensions from a limited range of motion laying down. We would push a wall isometrically, or we would do wall isometric squats. So ideally, in these isometric exercises, we would do 5 reps of 45 seconds of each of these isometric contractions, 2 or 3 times a day with 2 minutes rest. And as pain allows and as we build more capacity, we would increase contraction percentage. We would do a stronger contraction. Ideally, after 2-3 weeks where pain has decreased, where we feel more comfortable contracting, where we feel pain less often, we can progress into the next phase. So next phase is phase 2, concentric and eccentric exercises. As we progress phases, we always maintain the exercises of the previous phases. So examples that we could apply to the knee, we could do body weight squats, we could do lunges, we can do leg extensions in machines. We mostly start with lower loads and higher reps, like for example 15 repetitions of body weight squats. If for whatever reason 15 at the beginning is too much, we just do the bare minimum we can tolerate. And as we improve, we decrease reps and we add more loading. So what we need to do is build that capacity to exert force in a controlled manner. Again, as pain decreases and we can do most of these activities with no pain, which is probably gonna take longer time than the previous phase, maybe around 4 weeks, then we can progress to the next phase. So phase 3 is plyometrics. They are gonna be exercises with really fast contractions. They are also gonna be somewhat similar to what we may encounter in sports. So in this case, we would add lots of jumping exercises, lots of loading from one leg to the other, and quickly contracting jumping squats. At the beginning, obviously, we are not gonna start with lots of jumping. We are just gonna do maybe stepping down from some stairs and then jumping in a cushion surface. So it's just a thing about starting gradually and building more capacity over time. Again, we are gonna maintain previous phase exercises. So the last phase is return to sport. In this phase, we are gonna maintain all the exercises we've done, and we are gonna do a mix of plyometrics and sports related exercises. You know, if we are playing basketball, we are gonna start doing some throwing, some playing with the ball, some twists, some changes of direction, just getting our tendons again prepared for loading and for jumping and for reception. This is the 10 things not to do by Jill Cook. She's currently the leading expert worldwide in tendinopathy. So we're just gonna do a quick summary about them, about what things we should do about tendinopathies and what things we shouldn't. As we talked before, the rehabilitation process is mostly gonna be related to exercise, so it's not recommended to rest completely. Passive treatments, we will talk later about them, don't have injection therapies or invasive treatment. You know, they must be a second option after failing a rehab program. Ignoring your pain, the load is gonna be what tells us if we are doing the exercises properly or not. 5, I think, is one of the most important. Do not stretch your tendon. This is one of the places where we as healthcare providers, we fail the most. We usually recommend stretching when stretching is not recommended. So if you see in your rehab program that it has stretching, just try to avoid them. Also, massaging your tendon, avoid any friction to the area. Be worrying about images. As with lots of pathology, imaging doesn't fully show the whole picture of the pathology. Don't worry about rupture. Again, you would need to do lots of damage to your tendon to actually break it. Don't take shortcuts, and have a proper understanding of what loads are too high for your tendon, which we are gonna talk about afterwards. So first, how about passive treatments like ice or cold, like electric therapy, or like knee braces? How about them? Well, as we saw before, they are not really recommended. What I would say is don't fully rely on them and be careful with masking increases in pain. But if they are helpful for you to continue treatment and you understand that exercise is the main treatment, then it's okay. But if you don't need them, if you don't see any necessity, just forget about them. Exercises also have the ability to reduce your pain due to the release of different hormones and decreasing pain and different mechanisms that are gonna decrease your pain. About understanding pain and recovery, last tips I want to give mostly. This is the monitoring pain and load response model. The idea is that when we do exercises for rehab, it's normal to have some sort of discomfort. So this is what here it says from 1 to 10, a 4 or 5 level of discomfort. That's an acceptable level of discomfort. If we are stepping into 6 or higher pains, okay, then it's probably too much. But if we remain in this area, if we do our exercises, we notice, oh, it hurts a little bit in the area, but it's tolerable, then there's no problem. And also I want to talk about improvement in tendinopathies. Tendinopathies usually take a little bit of time. And this is a graph showing progress as time goes on. This is what we usually think will happen with injury. But in the case of tendinopathy, it looks a lot more like this. There's gonna be days where we feel like, oh, for 2 days in a row we've had no pain. Everything has been great. We are almost recovered. And then the third day, we feel like horrible again. The pain is back. It hurts a lot and we feel like we've lost all momentum. What I want you to get out of this video is that even the perfect rehab program looks like this. In every single injury, there's gonna be ups and downs, and we just need to zoom out and understand that we are improving in time. That either the tendon hurts less than in the beginning, it hurts less often, we are able to do more activities without pain than before, we are stronger, and such and such. And also a last tip, just do not really fear overload. Do not be really conservative with exercises. We, as healthcare providers and as patients, we tend to really underload tendinopathies. So just try to give yourself the best, monitor your pain, and you will see that your tendon actually has way more capacity and load tolerance than we actually think. Thank you so much for watching.